and welcome to another episode of the CSA's podcast, Vital Times. Today, I am really excited and incredibly honored to have two very special guests who are going to be talking to us about maternal mortality. The first is Dr. Diana E. Ramos. She is a distinguished public health leader dedicated to advancing the health and well being of all communities. She is actually the Surgeon General of California, and she is California's first Latina Surgeon General. Before that, she served as the Assistant Deputy Director of Chronic Disease Prevention at the California Department of Public Health, spearheading statewide initiatives to improve community health. Her leadership has extended across local, state, and national platforms, from serving as Director for Reproductive Health in Los Angeles County to holding key positions within the American College of OB-GYN and the American Medical Association Foundation, Women's Preventive Service Initiative, and the National Hispanic Medical Association. There is a lot to say about Dr. Ramos, but I really want to hear her talk. I do just want to make a couple more comments about her before introducing Dr. Calvin Johnson. Dr. Ramos earned her medical degree from Keck School of Medicine at USC, and she has served as an adjunct associate professor there for many years. She completed her OB-GYN residency at Los Angeles County USC Medical Center, and she also has a master's of public health from UCLA. Dr. Calvin Johnson is a professor of OB anesthesia at the Cedars-Sinai Medical Center, and he is also a member of the California Pregnancy Associated Review Committee, which is a federal committee that's run through the CDC and looks at pregnancy-related mortality and morbidity. And with that, I would like to welcome you both to the podcast.
It's great to be here.
Thank you so much for the opportunity.
And thank you both. I'm really excited to hear what you guys have to say. So I wanted to start with finding out, because we're talking about maternal mortality and morbidity in California specifically, but also nationwide. So Dr. Ramos, I wanted to start with you to find out, what is the incidence of maternal mortality in California, and how does that compare with the rest of the USA?
Yeah, so let's start with the USA. And in the US, maternal mortality rate in 2021 was about 33 per 100,000 births. And in California, the latest data from 2022 is 15 maternal deaths per 100,000. We continue, thankfully, to see a decline from the COVID peak, and we're on the right trajectory in terms of decreasing. And I do want to say that California does have the lowest maternal mortality rate in the country, and we still have a lot of work to do. But the rate really is lower because of the fact that we are working with anesthesia. We're working with really cross collaborative partners that make a difference at the time of delivery, postpartum, and preconception.
Dr. Johnson, is your committee also involved with determining maternal mortality or working towards decreasing that in either California or the US?
Our committee is specifically designated to look at the maternal mortalities in the state of California and look at the individual maternal mortality cases, look for systems, things that can be improved, not just from the medical side, but even looking at the social in terms of mental health, the social environment that the patient may have, and then again, finishing up with the clinical care that the patient has received and how there can be systems that can be put in place that can further reduce, just like Dr. Ramos mentioned, the maternal mortality in the state of California.
And Dr. Agarwal, I do want to highlight that I am so grateful that we have Dr. Johnson on our PAMR committee, because it is the work that he is doing, again, this cross collaboration that provides the data to really give us the direction in which to go. So really very thankful that Dr. Johnson is providing that time and expertise on the maternal mortality reviews for California.
Oh, that's great. That's wonderful. What is the most common cause of mortality? And we'll stick with mortality for right now, but also I'm interested in morbidity. But what is the most common cause of mortality currently for any mother having babies, either in California or the U.S. If you know that information?
Yeah,
Dr.
so
Ramos, yeah.
yeah, so I'll start. And it is cardiovascular disease in California. The latest data shows that 23% of the pregnancy related deaths were due to cardiovascular deaths, and this is really important to know because of the fact that 80% of those deaths are deemed preventable. 80%. So we're losing moms unnecessarily. And then the other thing to remember as an OB-GYN looking at the whole life course is that cardiovascular disease is the number one cause of death in women as well for all ages. So it's an important opportunity for us to use pregnancy as a reminder that we have work to do and we together can help prevent unnecessary deaths in moms.
That is just so interesting because that's actually not what, and in preparing for this, I did look at some of the materials that are on the website, which is fabulous, and will provide with the notes that go out with the podcast when it goes out. But I was really shocked that it's cardiovascular that's the leading cause of death. I guess especially as an anesthesiologist, even though I don't do OB, it's always the dramatic things that we hear about, right? Like hemorrhage or amniotic embolus or something like that. So I was shocked that it's cardiovascular. And is that the same in the rest of the US as in California? Is cardiovascular the leading cause of death for moms all over the country, or is that primarily California?
I think it's across the U.S. and the thing that goes unnoticed in this particular the CV cardiovascular disease is that it's missed opportunities in the antepartum and missed opportunities in the postpartum. That
Mm-hmm.
leads to the cardiovascular being the number one cause of mortality in women. And as Dr. Ramos mentioned, it underscores or it raises the question of just in general, why is cardiovascular death more prominent in women in general? And that's probably a topic for another discussion.
Yeah, absolutely. What about morbidity? Is morbidity also tracked in the same way that that mortality is, or is that not tracked in the same way? It's probably harder, right, to follow. Dr. Ramos?
Yeah, so there are proxy measures that are used, and some of those are ICU admissions, and as well as transfusion during immediately postpartum during delivery, and I mean, the estimates range for every one maternal death. I've heard it say that it's up to 1,000 near misses, the morbidity, and in terms of potentially helping save moms. And so this is an opportunity for us to realize that yes, maternal mortality, when you look at the data, is a rare event, but you've got so many more near misses. And I do want to highlight the fact that in California, the pregnancy related causes of death, hemorrhage, is 14%. And that, if you think about the numbers, is almost half of what the cardiovascular related deaths are. And it
Yep.
really is because of the fact that California has been very aggressive in developing hemorrhage protocols, and really it's been a team effort in terms of doing all of the simulation, implementing the protocols, providing the right care to our patients, that we've been successful in diminishing hemorrhage. As really, when we started out, it was the most common cause of death, and we've now cut that in half.
That's incredible. Dr. Johnson, is there anything you'd like to add on? Because I know part of your committee also tracks morbidity.
Yes, and I think what we've the underlying thing that's been the driving force behind the reduction really has been it all starts at the top. So the governor and then Dr. Ramos as the Surgeon General have been leading the way in terms of addressing this aggressively. And that really empowers the committee to go ahead and look at these things, address these things, and be able to see and implement system wide changes to further reduce death related to both cardiovascular as well as hemorrhage.
This this is just it sounds so impressive. I'm sorry, I want to go back to what you said, Dr. Ramos, about there's like 1,000 near misses for every death, which is, I mean, that sounds incredible. And is do you know, and I'm sorry, this wasn't part of my original planned questions, but is this work also being done in other states, or are we pretty much unique in how we're managing maternal morbidity and mortality?
Well, California was the first state to actually do the intensive maternal mortality reviews. And this is what Dr. Johnson helps participate in, helping us, California, review the deaths, really dissecting and understanding the causes and the opportunities for intervention. So we started this work back in 2004, I would say, more or less. And as a result of the data collection, the reviews, the development of the toolkits, other states have now adopted very similar maternal mortality reviews. So this is now becoming the trend nationwide, but California was the first state to actually start this.
Oh, that's and I assume like other states come to you for advice or resources in order to pursue these kinds of efforts in their own state, or is are they? Um,
Yes, and we are very open, very cross collaborative, and many of you may be aware of the California Maternal Quality Care Collaborative work, all of the hospital protocols, the toolkits. Well, all of that was really started as a result of the California Department of Public Health initiative to reduce maternal mortality when they contracted to Stanford, and they started the California Maternal Quality Care Collaborative. But it really truly is interdisciplinary and collaborative work. But nationally, anesthesia, the your organization has been very active on the AIM work that is going on nationally to try and reduce maternal mortality, coming and being an author on some of the ACOG recommendations on how maternal mortality should be managed. So, you know, anesthesiologists are true partners in in our work.
no, that's great to hear, Dr. Johnson. Do you want to add to that, or do you have anything to add to that?
Yeah, I think it's just been, as Dr. Ramos has mentioned, just a collaborative in which uh, each party is looking at working together to say, how do we address maternal mortality and morbidity collectively? And when you put, the brain power of all the subspecialties, anesthesia, OB-GYN, cardiology, you can then make headways into the problem of maternal mortality and morbidity. So that's one of the things I think has been great about the state of California, and is that how it has been integrating anesthesia as well as the other subspecialties to really work together to address this problem.
Are there other specific subspecialties that have been um, major players in this work? I can see why anesthesiology and OB-GYN would be leaders in this, and of course, as an anesthesiologist, I'm thrilled to hear that my specialty is very much involved. But are there other key players that are important in these efforts? I assume nursing has to have a significant role in some of this work too.
Absolutely. So if you just think about the team in the hospital, right? Anybody that has a touch point with moms, we want to make sure that we include all of the key players. So you mentioned it correctly. Nursing is one, the midwives are a critically important partner in terms of being able to partner with us. The neonatologists, all the NICU folks, right? Because when we
Yep.
deliver an urgent mom, you need that team member to be able to hand that baby over to care for the baby. So it truly is cross collaborative, and trying to find ways to improve our workflows, going through simulations.
Mhm.
Anesthesia has been one of the leaders in helping us walk through the most challenging case scenarios so that when they truly do happen, the whole team is ready to do the right thing.
Fantastic, fantastic. What are some of the risk factors that do increase mortality in the moms? What for the thousand near misses? What leads to that one mom passing away?
Well, I can start off, and I'm sure Dr. Johnson, from having reviewed a lot of the cases, can give you more. But generally, right now, some of the most common denominator of the causes are that women are waiting longer to start to get pregnant. And so, advanced maternal age, as well as chronic disease. So, 1 in 3 reproductive age women has an underlying chronic disease, and oftentimes they're untreated, undiagnosed, and women are starting pregnancy already high risk, and things just get complicated. So, we in my office have developed the preconception medical assessment in conjunction, I must say, with based upon 2 anesthesiologists. So Dr. Brian Bateman, who started out at the Brigham
Yeah,
and is now at Stanford,
yeah, he's right
developed the yeah, he
Mhm.
developed the OB comorbidity index. And Dr. Cesar Padilla, when he was at Stanford, helped us derive the preconception medical assessment from the OB comorbidity index. So it truly has been anesthesiologists that have geared a lot of my work here in my office to the preventive, the the oversight of being able to identify those people who are going to be at higher risk or need more care if they become pregnant. So that's prima. And the other is, really that the partnership. So I'll start there, but it is chronic disease, advanced maternal age, and now we have that resource through our preconception medical assessment, 8 questions to identify those moms that are going to need more care. And hopefully it will provide the opportunity as a conversation starter for them to go get the care that they need before becoming pregnant.
before. So this is for before preconception.
Correct.
We'll have a link to that on the podcast liner notes, so that to Prima as well as some other information from your office. Dr. Johnson, do you have anything that you'd like to add to that? That's this is so interesting because this is so far from where I thought we were actually going to be. Again, I always think of things like hemorrhage and sort of the dramatic things that we think about leading to death, and not so much about the chronic illness, and yet clearly that is such an important part of all of this.
Yeah, one of the other things to add as far as the chronic medical situations that we've discovered is that obesity. Obesity by itself has underlying cardiopulmonary stresses. And then when you add that in terms of the physiological changes of pregnancy, that compounds things. So just like Dr. Ramos mentioned, advanced maternal age, et cetera. When you start adding things like obesity, that also adds to further risk factors for an adverse outcome in these moms.
So going back to Prima, then is the idea that families will do this before they conceive a child, and then try to optimize the moms will try to optimize their health before becoming pregnant. But what about if they're already pregnant? Is there anything really that they can do at that point?
Yeah, so you bring up a good point, Dr. Agarwal. So Prima is meant to be completed in the community where people live, where they're doing their daily activities. So we've partnered with the YMCA, we've partnered with other medical societies and with community organizations to post Prima. And if a person happens to see it, they will complete it right then and there. And it gets them thinking. The logic being that oftentimes we prepare for a wedding, we prepare to get our driver's license, we do a lot of research to get into college, into medical school. But how many people actually do a lot of research on their own health before becoming pregnant? And that's where PRIMA is. So we took that OB comorbidity index and simplified it for the layperson. And then during pregnancy, the most important thing is to get the prenatal care. Get the
Okay.
prenatal care early because of the fact that there may be chronic medical conditions already present, and to get the care the earliest, and the most intensive as needed will help make a difference in the trajectory of pregnancy. Something as simple as low dose aspirin, 81 milligrams, a baby aspirin a day. If somebody has had the history of hypertension in pregnancy from the previous pregnancy, that can help decrease the risk for the preeclampsia to happen again. So there's proactive things that can be done, and all of those recommendations could be made once prenatal care is started. So early prenatal care is critically important.
Do you, Dr. Johnson, you had mentioned obesity. Do you, if somebody comes in and they're already pregnant and they have obesity, you don't, do you recommend weight loss during that time, or is it just careful diet and nutrition at that point to help support the baby?
Well, one of the things that we're learning through the committee is that looking at a more in-depth cardiovascular workup. Perhaps
Okay.
that patient should have an echo cardiogram in terms of so that look at and see is there any underlying uh, cardiac dysfunction that is not symptomatic but could be later on, could lead to cardiomyopathy postpartum. And so those are the things that we're learning from the committee as we review these, is that there are some chronic medical situations that if they're carried over into pregnancy can unmask uh, a potential disease in the cardiovascular arena uh, that maybe we can address earlier.
Great, great. I want to switch switch questions just a little bit. It's still about maternal mortality and morbidity, but I know, Dr. Ramos, you've been involved with addressing adverse childhood experiences, and I know that you have a section on your website about this as well. And I know, Dr. Johnson, you've also brought this up. But what role do ACEs, or adverse childhood experiences, play in increasing or decreasing maternal mortality and morbidity?
Yes, so this is critically important to understand. And I know oftentimes as physicians, we are trained to treat, the disease that is in front of us. But what about if we can actually prevent the disease from happening, right? Dr. Johnson mentioned obesity. We've mentioned heart disease. We've mentioned hypertension. What about if we could prevent that? And that's the opportunity that addressing the adverse childhood experiences does. So, adverse childhood experiences are things that happen to us before the age of 18. So, three buckets: abuse, that could be physical or emotional; neglect, again, physical, emotional; and then there's household challenges. And that ranges from mental health disorders in the family, so depression, anxiety, and either one of the parents. Could also be divorce, abuse, intimate partner violence. All of these things are bucketed under adverse childhood experiences. So Dr. Vincent Folletti, he's still alive, a preventive medicine physician, was working for Kaiser Permanente in San Diego in the late 1990s, and he had a weight loss clinic. And what he noticed was the fact that patients would lose up to 300 pounds 300 pounds in a year, if you could believe that. Yes. But then what would happen is that they would gain the weight back, and he saw this happening over and over again. Finally, he stopped and he asked the patient, is there something that I should know as to why you're gaining the weight back? And one patient told him, you know, the weight is actually protective. And he said, what do you mean? He said, the weight protects me from being seen. The patient had said and shared that when she was 8 years old, she was sexually molested by her father. And she was thin, she was pretty, and that's what her father would tell her. You're thin and you're pretty, and he would molest her. She said, I had a younger sister who I encouraged her to overeat so the same thing would not happen. And she went on to share that it was finally when she gained the weight that the sexual abuse stopped. So she said, now that I lost all of the weight, now my boss is coming on to me wanting to have sex with me. And she says, I'd rather be protected by the weight and not be seen. And that was the reality. And then he started to ask all of the patients who started to undergo, have that same pattern. And that's where the realization came about, that it was many of the things that happened in childhood that really were um, a trajectory to the negative health outcomes. So now we know that if we address ACEs before the age of 18, you can actually prevent 44% of mental health disorders. You can prevent 30% of smoking, of alcohol abuse, of chronic disease. And the reason being is the fact that we as humans will do certain behaviors to help relieve some of that negative stress and anxiety, try to change our state when bad things are happening. And we can do that through whether it's alcohol, drugs, and even using food as a way to modify our feelings. That is what ACEs are all about. So as an OB-GYN and California Surgeon General, I saw this as an opportunity. Wow, if we address ACEs in reproductive health people, if we address ACEs in pregnant moms, we are actually impacting not only the health of moms, but the health of that baby and the family itself and the community. It's a big ripple effect. So that's the reason why we are addressing ACEs, because it's an upstream approach to improve health. So this is the one prevention and the one thing that we can address. The great thing about ACEs in California is that you actually will get reimbursed $29 to complete an ACEs screening and referring a patient to the support that they need. So California not only is leading in terms of addressing ACEs, but really reimbursing providers for the care that they provide to patients. Really, it's an upstream approach.
Absolutely.
Oh, go ahead, Dr. Johnson.
Oh no, the ACEs, as Diana mentioned, the ACEs it really is a game changer because we can see uh, without the ACEs, we're seeing the effects of and the maternal population by the time they get to us in the committee review, and an earlier intervention would have a significant impact on the things related to mental health, etc., that Dr. Ramos has already mentioned.
And I just wanted to clarify 2 points that you made, Dr. Ramos. Um, you said that in California, providers, I assume physicians, nurse practitioners, PAs, whoever is screening these patients actually get reimbursed. Is that unusual? That's not something that happens elsewhere?
You called it. It
Wow.
is
Absolutely.
unusual.
Yeah,
Okay.
And again, it just shows to the leadership of California and
absolutely.
recognizing the importance of prevention and an upstream approach.
Wow. And then when you talk about addressing a referral, is it really primarily mental health support that most patients need, or is it other things as well?
It is really a combination and it depends on the person. So
Okay.
mental health is one type of ACE, and there has been millions of dollars invested in behavioral health, and behavioral health includes substance abuse as well as mental health. So it really depends on the person. The beauty about California is that we have resources that have been created and identified depending upon where in California you live. because we know that the needs are different based upon geography, based upon resources, and the population that we serve.
What could I, as a physician or as an anesthesiologist, and I'm not an OB, I do pediatric anesthesia primarily or exclusively, but what could I, as either a pediatric anesthesiologist or any anesthesiologist, do to help decrease any of these risk factors?
I can start and then Dr. Johnson can
Sure.
follow. But I would just say, well, one, awareness. And by listening to what we're saying right now, it's the first step. I would encourage folks to go to the ACEs Aware website, which is the California Department of Healthcare Services website on ACEs, and you can be certified for to be able to bill. You have to do a 2-hour CME course. But then the other thing
And
too,
that's open to anyone? Anyone
that is
in
open to anyone. If you have an NPI number and you are in California, you can go on there, take the course, and then start billing. So yes. So social workers as well. So if you have one on your team that you work with, because healthcare is a team approach, then they can also do it. But I would really want to remind all of the anesthesiologists of the important role that you play behind the curtain. And what do I mean by that? The conversations that you have with the patient, the conversations that you have with their partner when they're there on the table is so critically important. So, words from you are the one that is oftentimes keeping the patient calm. You help continue that continuity of trust that the surgeon has started. And I can't thank you enough, all of the anesthesiologists, for doing that, because I was always so comforted to know that my anesthesiology partner was there calming my patient, keeping me calm when things were intense. But you really are such a key player in the conversations and reinforcing what's important. So thank you.
Thank you, Dr. Ramos. Dr. Johnson.
Yeah, I think as anesthesiologists, or actually, we became physicians first, and then we became anesthesiologists. And I think as physicians, as we care for our patients, having the knowledge and the foundation of the ACEs program as we interact, as already been mentioned, with our patients, it's critical. Whether or not you choose to go get certified, I think it's for billing purposes. I think as an anesthesiologist, it's something that to become knowledgeable and certified in, so that we have another tool as we talk with our patients pre and post anesthesia, as we talk with the community about anesthesia. I think that is something that is invaluable as an anesthesiologist, because we do have a unique role in that we may be seeing patients, we do see patients at some of the most stressful times, and they confide in us different life situations as long as we ask the questions. And that does have an effect on their overall care and the trust that they have for physicians in general.
Oh, that's fantastic. Yeah, this really gets me to thinking about, especially as we talk about the ACEs part of it, because obviously I see children after they've already been born, and it gets me to wondering, how would I recognize if there was an issue that needed, that needed further exploration or needed further addressing, like you mentioned, kind of outside of the whole OB maternal mortality range, but more in the, the child who presents for a procedure, or I also do pediatric pain, so perhaps, the child who's coming in with a chronic medical condition and or chronic pain. How would I recognize these? So even though I don't know that I would ever be in a place where I would bill for it, I'm really intrigued by taking the course and at least increasing and improving my awareness of those kinds of things when I'm taking care of patients. Is
So,
there?
so I do
Go
want
ahead.
to share. I do want to share, Dr. Agarwal, that for the pediatric um, patients, it's the parents that complete the ACEs screening, and so that, if anything, especially if you take care of pain in children, I would say have them complete it. And if they are being cared for here in California, then it may be in the medical record for the child that the ACEs screening has already been completed, and you can look at their score and perhaps use that starting point as a conversation with the parents and helping the child.
That yeah, that is I know that, and I feel like I should know this better, but I don't. I know that at Stanford, where I work, there are questions that are asked about like food insecurity and transportation insecurity and home, like living conditions. I don't know specifically what else is routinely asked, but I'm definitely really intrigued. I will, once we get done recording, I'm actually going to start looking at some well, when I see my patients for tomorrow, I'll look at, because I don't want to break HIPAA, but I'm just curious as to what we do ask, and if it's that formal ACEs questionnaire, or if there's something different. But as I said, also for myself, I really like the idea of taking a 2 hour. You said it's a 2 hour course to become more intentional, maybe about understanding what is happening in my patients' lives before they come to the hospital, whether it's for surgery or for something else. Um, what else do you think? And you've talked a lot about the role of anesthesiologists, and I'm so grateful to know that we are so instrumental. And I'm just so I think it demonstrates so beautifully how collaboration and physicians and other healthcare professionals working together can make such a dramatic difference in patient outcome. But is there anything else specific that you think anesthesiologists should know about either maternal morbidity and mortality or ACEs? And again, I'll start with Dr. Ramos and then go to Dr. Johnson.
Yeah, I would say that, in preparing for our talk and our conversation right now, I had the opportunity to pull up the American Society of Anesthesiologists, the statement on anesthesiologists' role in reducing maternal mortality and severe maternal morbidity. And I was pleasantly surprised to see a nice summary of the really that codifies the partnership that I already experienced in the OR and in the hospitals, but it's in writing. And to see that anesthesia has the SOAP, the Society of Obstetrics, Anesthesia, and Perinatology, it's fantastic. So I would say, please continue your collaboration and continue the work that you're doing already. The diversity of thought helps us all become much stronger.
Thank you. Dr. Johnson.
But just in terms of, I think, realizing that with the application of the ACEs is that learning that it's physiological, as not just psychosocial, and that the toxic stress impacts anesthesia responses and hemodynamics, and developing supports that support the maternal care, the parental care, the child, so that we can really provide in some ways, you can look at it as a holistic approach to our patients. But I think ACES really does help us with a template to really base on for providing care to the moms and the kids and the families that we're taking care of.
That's great. I know Dr. Mark Zakowski has been very involved with, I think, both SOAP. I don't, he's one of the former CSA presidents. I want to say he was a SOAP president, but I actually don't know that for sure. But I know he's been very involved with creating a lot of the OB guidelines through the ASA and trying to improve maternal outcome overall. So, and he's from California, so that's wonderful as well. Is there anything else that either of you would like to share with our listeners regarding maternal morbidity, mortality, or really anything else at all that you'd like to talk about? And again, I'll start with Dr. Ramos.
Yes, no, thank you for the opportunity, first of all, to have shared some time and space with you. But the one thing that I do want to highlight is the fact that maternal deaths are preventable. Over 80% of maternal deaths are preventable. And we can all do something in caring for our patients, especially after the baby's born. And what do I mean by that? Well, 60% in California, 62% of the maternal deaths occur up to 1 year after the baby was born. So you mentioned, Dr. Agarwal, that you sometimes will care for in the pediatric population. This is
Mhm.
the opportunity for you to perhaps have a conversation with a mom and say, how are you feeling? How are you doing? And I know you can't bill, but just being, asking the simple question can make a difference in encouraging her to get the care that she needs. Many moms will not go to that postpartum visit because they're too busy, especially if they had a newborn that was in the NICU, right? And they had maternal complications. So don't lose sight of any opportunity that you have to interact with a new mom and help them really care for themselves, because we know that when we take care of ourselves first, there's more available to take care of everyone else around us. And I do want to just share that we are going to be launching, along that same vein, a campaign, a grassroots effort called One Small Thing. And One Small Thing is going to be a call to Californians to do one small thing for a new mom. And that could be as simple as taking her to the doctor's office for her appointment, or sitting with the baby while she takes a shower, or going to the market, delivering food. And we can really be the touch point for a new mom, because we know it can be a very isolating time when you have a baby, and it could be very exhausting. So we can be the eyes and ears in the community to help prevent those 62% of maternal deaths that happen after delivery.
Can I, I'm sorry, before I ask Dr. Johnson, two things that you said. So the 62% of maternal deaths that occur after delivery, are those thought to be related to the pregnancy, or are those just, that's just the way they're counted? Or is there something about
It's
becoming the
pregnancy
mother
associated.
associated? Okay.
Pregnancy associated, the number one cause, cardiovascular disease.
Still, wow. Wow. I'm just stunned by that. I'm still really stunned by that, and the fact that that California's love rate is so much lower than nationwide, and yet we still have such an incredibly proactive, active Surgeon General who's really promoting more. Dr. Johnson, sorry, I do want you to have an opportunity to speak here as well.
Well, again, I want to thank Dr. Ramos. I mean, she's been just an advocate that's really made a significant difference. And I think, as far as anesthesia specialists, my advocacy would be just to make yourself aware. I'm an obstetrical and a pediatric anesthesiologist, so I'm involved in it. But even if, as an anesthesiologist, you're not in those specialties, but making it a responsibility to learn as much as you can about maternal health, maternal morbidity, maternal mortality, because you will speak with moms and dads for a variety of your anesthetic care that may not be directly related to maternal or pediatrics. But I think this having that awareness among our specialty can bring so much more of a positive experience for our patients.
Thank you both so much. This has been such a great conversation. I know that I have personally learned so much, and I hope that our listeners have as well. Before we sign off, any other last minute comments that either of you would like to make? And again, Dr. Ramos first, and then Dr. Johnson, and then we'll stop.
Yeah, I just want to again reiterate and thank you for the opportunity to speak with the anesthesiology audience. And again, to thank every single one of you anesthesiologists to really being a true partner and helping us care for our patients when they need us the most, when not only they need us the most because you help relieve pain, but as partners, especially when we have emergencies in the operating room. I'm always relieved to have my anesthesiology partner in the OR with me to help manage all of those surgical crises. So thank you for everything that you do.
Thank you. Dr. Johnson, any last minute comments?
Yeah, I just think that I want to give special kudos to both the governor and Dr. Ramos, because in any organization, if it doesn't start at the top, if the concern and the innovation and the implementation doesn't start at the top, and that's what gives us as healthcare providers the ability to make changes in the care that we provide for our patients, because our leaders care. I think that's so important, and that's California leads the way in that regard.
Great. Well, thank you both again so much. This has been another episode of CSA's podcast, Vital Times.